Well, hi everyone, and welcome to our final preceptor development session of the year. All of you know who I am. I'm hoping you can see my screen. You cannot see my screen. For some reason, it stopped sharing. Is it sharing? Can you see my screen?
Yeah, we can see it.
Oh, perfect.
The slide deck.
Yes, the slide deck.
The notes sort of section.
And it's fine. I'm going to leave it that way. I'm not going to change it to the presenter view because my computer's been slow. So this session is our final session of the year. We will be transitioning to a UC collaborative type of format in the future, where all of the UCs will be presenting a session, at least one session per year. And so this will be our final UCSF homegrown UCSF given session. So thank you for attending it. Today we have a double header of Dr. Laura Quintal, followed by Dr. Tram presenting on the topics of best practices for co-precepting learners and emotional intelligence, respectively. Here are our learning objectives for this whole series. They're the generic learning objectives that are provided in our CE provision. So you will be receiving CE for this, for your attendance. I'll send out a Qualtrics after this session, which will serve as your CE credit gateway. These are the disclosures stating that no one who's presenting today or has had any role in the planning of this event has any financial relationships to disclose with ineligible companies. And this is the accreditation information for this sessions. As I said, there's no charge to receive this, and I will send out a Qualtrics as your gateway to receiving CE for this credit. You can expect to see that about 2 to 4 weeks after that. And with that intro, I will stop sharing. I will hand it over to Laura, who is welcome to begin whenever she is ready.
Thanks, Dexter. All righty, hopefully this. So I'll be discussing today best practices for co-precepting learners as part of the development series, but I was intending for this to be more of a discussion where we could share some pearls because many of us already have had different experiences and opportunities to do precepting. And it's just kind of like another fun twist to co-precept. So here are the objectives for today: to understand the role of the preceptor, to identify co-preceptor models, explain the different responsibilities of the layered learning practice model, and to identify tools that will allow co-precepting to be successful. I think we have to go back to the beginning for when we went to pharmacy school and took the oath of a pharmacist, specifically the point where it says, I will utilize my knowledge, skills, and experiences and values to prepare the next generation of pharmacists. And I think that this is really relevant today and where we're working, and just something to remember that for me was many years ago, but that we should continue to try and strive for. If you can put into the chat, I'd love to see and kind of poll the audience to describe the types of learners you've precept or that you do currently precept. I have listed here PGY2, PGY1, APPE students, IPPE students, all of the above. Some models also include, and even working at UCSF, opportunities to precept pharmacy technician learners or externs, or even in the hospital when we work with interns. And it seems like Kathy and Nita, you guys have had an opportunity to precept a lot of different, and Dexter have a lot of opportunity to precept various types of learners, which is great. So I think one of the really important things to realize why we want to think about co-precepting is the number of learners is increasing. In 2021, the ASHP pharmacy residency match listed more than 5,500 residency positions available. And if you look back, I think at that time, there were well over 6,000 applicants. So the number of people who who want to become learners in terms of a resident, and the number of residency positions is continuing to grow. In the past 5 years, PGY1 positions have grown by 27% and PGY2 positions have grown by 55%. And that's a very large number, and it continues to grow. Also, just within California, there are now 14 ACPE accredited schools of pharmacy. I think this graph here, just looking back at the 90s to even 2020, just shows the number of students who are enrolled. We're approaching 5,000 students who are enrolled in the schools of pharmacy in California, and that's a very large number. And who's going to teach all of these students when they go on rotation, or who's going to precept all of these residents when they match? And that's going to be us. It's going to be residents. That's going to be those of us who are working. And really, we need to just remember what the role is that we take on when we are the preceptor, whether it is a one-on-one model, which we are traditionally used to or often used to, or whether it's a co-preceptor role. It always starts back to the fundamentals, where we start with direct instruction with our residents and our learners. We need to make sure that they understand fundamental concepts. Those can be in the form of assigned readings, reading guidelines, giving them lectures, whether that or referring them back to their lectures from the didactics, or even conducting topic discussions with them. And then that'll move on from there, after you've built that foundation of the concepts, to modeling, where you are able to demonstrate a skill or a process. And that's when you interact with your team, when you interact with other healthcare providers, in the way that you communicate with them verbally or in written communication, your body language, how you approach them. The modeling is just a really important part of allowing the learner to see and have you demonstrate for them what it should be that it looks like to be successful as a pharmacist. The other thing that we're supposed to do when we're preceptors, we should be explaining our thought process, or having the learner explain the thought process before and after the activity. We should also try to do that too. I think sometimes we get into the thought of, okay, I'm just going to go in and I do my work, and but in our modeling, we should be able to explain to the learner how our approach is going to be. And then the next piece that we move to is coaching. And when we are coaching, we observe and we assist the learner in patient care activities. We guide them through problem solving. This is when we ask, a lot of this is, asking them questions. Why do you think this is happening? Having them dig further in a mechanism of action, or why a drug adverse event might be occurring because of the side effect of a drug. And in this coaching, we also want the learner to describe their thought process to us as a preceptor. And then finally, facilitating the learner to work more independently. We want them to perform a lot of these after they've achieved all of this. We want them to perform a lot of these activities independently, whether that is making recommendations to their team, approaching their team to make recommendations, whether that is rounding on their own with slight oversight, or whether they take the lead on a particular project. All of those are to be facilitated by those of us who are their preceptors. And then the last thing would be the learner would hopefully need to only ask the preceptor for assistance, as the preceptor can step back and more serve as a resource rather than someone who is actually taking full independent autonomous role in part of the team. So there are a couple of co-precepting models that we can think of. The term co-precepting, it's applied when two or more practitioners share the responsibilities of a primary preceptor. The more traditional sense would be where you have two pharmacists to one learner. I think we're with availability of resources, that's not always the most readily available thing to do. So what has been more instituted is a layered learning practice model. And that layered learning practice model takes on a couple of forms. The first one is the traditional form, which is on the left, where you have a pharmacist, a resident, and a student. And that will be the one I'm going to focus on today. And then there's probably a more complex model where you'll have a pharmacist, a PGY2 resident, a PGY1 resident, an APPE student, or even a paid intern in some institutions that have a clinical internship, and even an IPPE student. I think that the complex model is typically reserved for, it's since it is so complex, we typically reserve it for areas in which they can accommodate it, maybe more specialized areas, or areas like a clinic potentially. So the first thing to discuss is, what is the pharmacist's responsibility in this layered learning practice model? And the pharmacist is essentially supposed to oversee all the patient care activities and the precepting responsibilities. There's to create a resident syllabus. And I would say many times all of us also create that student syllabus as well, which is typically separate. The next thing that we would be, once you've created that syllabus, would be when the resident starts, you want to orient the resident to their syllabus. You want to orient the student to the student's syllabus, and then orient both to the practice model as well as the site. So there are some things that can be consolidated, such as orienting to the practice model and orienting to the site. But I think that in the literature, when you read it, each resident and student, or the resident and the student, need to have their own independent orientations. There's some literature out there to say perhaps meeting before a rotation starts would be the ideal time to orient a resident, but I find that to actually be very, even especially at an institution like ours, possibly like an unrealistic expectation to meet with the resident beforehand. Just because I think that residents are busy. I wouldn't want to take time from an ICU rotation so that they're trying to start already thinking about their oncology rotation, for example. So I think that would probably be at the discretion of, say, I would reserve that to just keep the orientation to the rotation at hand that the resident is with me on. But you'll find different suggestions in literature. The really important thing is to set the expectations for the residents and the students. And based on the syllabus, they're going to be very different. And that's why you need to meet with each of them separately. And you can also meet with them together. But I think when you're setting the expectations, the most important thing that you're doing there is essentially delineating what roles and responsibilities are going to go out. And part of the success of co-precepting is having very clear responsibilities and roles. Otherwise, there's going to be a lot of confusion as to who is doing what and who should be interacting with whom. The other thing is that you as the preceptor should be doing is evaluating the resident for their clinical performance. That's why they're on the rotation to not only teach with the learner, but actually to also gain clinical insight through that experience. And so you should continue to evaluate them. You should also assist the resident in providing feedback to the student. In my experience, and we can all share, but in my experience, I like to reserve setting aside time with the resident and hearing what their thoughts are about a learner, just so that they have that time that's like protected and dedicated, and to focus on that teaching aspect. I think that allowing them to focus on that just compartmentalizes all of their, helps compartmentalize part of the many responsibilities that they have on the rotation. It also allows them to kind of have a lot of autonomy to learn and do their own assessment of the learner or the student. And of course, the last thing we do, in addition to the clinical performance for the resident, is evaluate them in their precepting performance and provide them feedback. I think the resident in the layered learning practice model has one of the more challenging situations in terms of having to balance. But if you can set them up for success, these are a lot of the suggested responsibilities in the literature. It's making sure that they coordinate the learning experience with the primary preceptor, whether that's their own, but also with the student. So some examples can be, let's say the resident would prefer to do drug topic discussions with the learner, or that the learner would, or that the resident prefers to do the card flipping for patient rounds with the learner, and then check in with the primary preceptor. As long as you are doing the coordinating and delineating who is doing what, I think that it makes very clear for the communication. The literature indicates to have the resident create the student syllabus. I would actually take this with a grain of salt. I think that residents are very, very busy. And a lot of times our rotations, medicine, oncology, ID, they already have a syllabus for the student. It would just be, my thought would be, rather than creating the student syllabus, is to review the student syllabus with the resident and identify the areas in which makes sense for the resident to take on certain responsibilities in oversight of the student learner. And then, of course, you can give the resident the opportunity to orient the student to the calendar and the rotation activities. If they are starting at the same time, it might make sense to do both. It also depends on how busy the resident is, but you can consider having the resident take those on, since, you know, if the student's rotation starts, say, once the resident has already started, the resident may be in a position to do all of those things, to take the lead for those, because they may know the service, they may know how everything operates, who is the verification pharmacist, or you know, how discharges occur. That those could be some feasible activities that a resident could take on. As mentioned earlier, the resident could potentially lead topic discussions. And I think having that conversation and planning ahead of time with the resident, these are the topic discussions that are set for the rotation, discussing with the resident which ones they could potentially take on is always helpful. And the next part for the resident to help learn to do is to integrate the student into the patient care activities. I think some services have, like to have the student take on a few patients, or have the resident and the student on the same team. There are other services where the resident and the student have separate teams. And I think that just has to do with how the rotation is set up and how those practices are. I think oncology has, you know, since they have several teams, or medicine may have several teams, it's feasible for a resident to take on, you know, their own team, and a student to possibly take on their own, depending on where the student is in their acute care rotation year. The other thing that is really important for the resident to learn to develop is to provide formative and summative feedback to the student. It's like a really great teaching tool for them to have it be very structured, and to develop a plan to do that with the learner. I think the learner's activity, moving on to the last piece, the learner's activity is hopefully going to be more straightforward for the learner, where they're reporting directly to the resident. They actively participate in patient care, whether that's participating in med rec, discharge counseling, or providing recommendations to their team. And then, of course, providing feedback to both the resident and the primary preceptor on the rotation experience, but also, you know, on, I think, just feedback for teaching, and those things are welcome as well. So in that model, it's almost like a trickle down, where the pharmacist is in constant communication with the resident learner, and then the resident is the primary one who interacts with the student, but the pharmacist will also have the opportunity to check in on the student. I think in the literature, it's difficult to find, but we have actually seen published examples of successful implementations of layered learning practice models. At UNC, they actually, I think, were the first publication or first site to publish. Back in 2010, they implemented a model, and recently, or in 2016, published about their model. But what they created was a model in their oncology service where there was a clinical specialist in oncology, either a PGY2 in oncology or a PGY1, an APPE student, and a generalist clinical pharmacist, one who could possibly do most of the order verification. They measured many different things, but I wanted to just kind of highlight the outcomes of the publication. They were able to show that APPE students performed 30% of the med reconciliations, and also upon discharge capture, they were able to do med rec and counseling for at least 51% of the patients. And I think in terms of medication related problems, they caught anywhere from 1 to 2 with each discharge. They measured their time and spent approximately 20 minutes of face time per patient. Taken together, I think all of the outcomes of this study were just able to show a few things. Number one, implementation of a layered learning model was able to incorporate APPE students into direct patient care. They were able to expand services because without the learners, the residents and the APPE students, they wouldn't have been able to increase that rate of discharge capture, as well as identifying medication related problems. And then I think they were able to spend time with the patient or face time with the patient, where previously there wouldn't be one without this model. And then there was another hospital as more of a non-academic medical center, the university's hospital, Giga, I think it's how it's pronounced, medical center. They had a model in which they incorporated a layered learning model with APPE students, and they had very specific outcomes that they were looking for. And what they were able to show was having a pharmacist involved, including a resident or a learner, was able to significantly lower the total drug cost per discharge. It was, I believe, it went from like $200 per discharge cost to $150. And then, of course, they also sent out surveys to patients and compared it to sent out surveys to patients. And the patients who had interactions with pharmacists had a more noted patient satisfaction compared to patients who did not have any interactions with a pharmacist. However, I want to just recommend that, or say that the layered learning practice model has many challenges. There are challenges for the learner. If you are a student and you are in that layered learning model, you're interacting with different preceptors. And one of the challenges is that you may experience some anxiety because you're trying to meet the expectations of different preceptors. And then again, it is so important to set up clear expectations together with the resident as a preceptor, because as a learner, you're interacting with different members of the healthcare team or staff at a practice site, and you may not be clear of what the expectations are. And then when there are multiple learners with 2 or more preceptors, a good example would be an anti-coag clinic when we had, say, 2 pharmacists or 3 pharmacists, but there were 5 pharmacy students. It can be very difficult at times for preceptors to get to know and then to assess individual learners. It gets to be a very busy environment. And so those can be a challenge for the learner. The challenges for the resident, and though it may not seem like there are many, I think the biggest one that we are aware of is that they need to figure out a way to maintain a balance between their own learning and their ability to teach. Once you take on the oversight of a learner and the learner's patients or the learner's responsibilities, it becomes a lot more difficult to divert your attention solely on just your patients. And then you're going to have to be concerned for your learners' patients. It's just a very challenging balancing act. The other thing is, for even as a preceptor, but once a resident takes on those preceptors role, the independence and autonomy for the learner and how to develop the learner's practice is going to be important, as well as their own practice. And I think that those things are to be appreciated, because it can be a very difficult thing that a resident spends the whole year learning. Challenges for the pharmacy preceptor. Of course, since you're overseeing essentially multiple learners, you have to continue to ensure patient safety. And so you have to have, maintain oversight, while maintaining independence. One of the things that is going to be challenging for our pharmacy preceptor is going to be assessing the competency of the resident. There are some residents who may not be as proficient. It could be because this is their first acute rotation, or the rotation is incredibly subspecialized. It may require the lead pharmacist to work with the resident more closely, and develop a more comprehensive plan for gaining their own independence, versus a different setting where you could be in a clinic overseeing primary care disease states, or potentially on general medicine, where many of our residents come in because they've taken that rotation already. A lot of challenging things for a preceptor: if they have responsibilities where they have to do order verification, they're going to have to monitor that a lot more closely as well, because you're going to have to make sure that whatever recommendations come through, whatever orders come through, you'll have to look at those. There are also scheduling challenges. What do you do if the resident learner is out or has other meetings and obligations, or if you are out, how do you ensure that there's oversight for both the resident and the learner? And then, of course, we don't have a problem with this at UCSF because, our residency program is very robust, but ensuring that pharmacy preceptors are qualified. This is probably like a more challenging thing at smaller institutions, but that's why ASHP has the APRs. In the more specialized services, you can have a limited number of staff, you can have a limited number of residents, or even just limited number of students. And then again, you can have very complex patient populations that make this challenging. ICU is a really good example. I don't think that everybody can grasp ICU or some of the more specialized areas very right off the bat. And so a lot of times there's a certain onboarding or certain foundational concepts that really need to be established in order for your resident to succeed in their own learning, as well as the learning for their learner. However, there are so many benefits of having that layered learning model. For the pharmacist, it's an opportunity to expand the clinical pharmacy services with existing resources. You can increase opportunities for direct patient care for everyone. It also expands the pharmacist's use of time. If your resident and your student are able to help with some of the counseling, if they're able to help with some of the medication reconciliation responsibilities, it allows for the pharmacist to focus on projects or participate in committee work. It also allows for increased support and guidance for junior preceptors, or even residents, if you want to consider them junior preceptors, or preceptors in training. I think that rather than what a lot of times people call throwing them into the water or trial by fire, you are still providing guidance with that model. The learner is also exposed to different practice styles and a more diverse set of learning experiences. A lot of the clinical experiences coming from two preceptors can be very valuable versus having just that one-on-one model. And one really important thing that we love to emphasize is that the layered learning practice model really can promote student interest in clinical pharmacy and potentially their interest in pursuing a residency and further their learning. Additional benefits is that the learner can develop their own independence and autonomy under the guidance of multiple people. I think there are some studies that have also shown that the satisfaction of the physician team is increased because the perception is that they feel that they have a dedicated pharmacist that they can go to. The layered learning model also allows for more one-on-one time for the learner with a resident or a pharmacist preceptor. The other thing is that you can have improved patient outcomes, as a few of the studies that we've previously talked about have been able to demonstrate. And then we have greater intervention opportunities that can affect patient care, as previously seen in those studies. And of course, improve customer service and satisfaction, not just to our team, but to nurses, to other providers like our NPs, mid-level providers, and other colleagues. And then again, when you have this layered learning model, you can potentially accommodate an increased number of learners, as we've seen that need is there. So I think one really important piece as I go into kind of the structure of what is needed for success of co-precepting, I think this is actually the most important piece, and it's planning. The planning piece is going to be probably the piece that if you invest the most time, it will pay off the most. And that includes setting up your syllabus or your learning experience appropriately, meeting with both the resident and the student separately, and then setting clear expectations and responsibilities. When you meet with your resident, you want to ask them or discuss with them what are going to be the learning expectations versus their teaching expectations. Always ask a resident how comfortable are they with co-precepting and taking on a learner. I would say it's going to vary at various times in the year. All of our residents are new right now, and so they may all be quite hesitant versus at the end of the year when they take on a learner, and they've gone through the whole year, they may be incredibly comfortable having done it throughout the year. I think a good thing to ask is how much do they want to take on and with which responsibilities? Do they want to round with the learner? Do they want to do topic discussions with the learner? If this is a clinic, how much clinic time do they want to have shared with the learner? Do they want to share a team, or are they each overseeing their own team? Or perhaps it's a little bit of, developing a plan for independence for that learner, just checking in with the resident that there is one. The other thing is discussing with the student their learning expectations. I think a really important thing to talk about is the point of contact. Who should the student check in with when they have to discuss recommendations, or they need a resource to go to? Who should be the first resource, and the feedback? Hello. Hey. Sorry. The next thing is to assess the resident and student learner and their baseline. So you want to inquire about prior rotation experiences. I find that to be very helpful. If, for example, this is their first acute care rotation, you're going to approach it differently than if it was their third. Or if this is their first clinic rotation, you're also going to approach it differently than if they've never had a clinic rotation. I think and this goes back to preceptor basics, but learning style inventory is so important. Not everybody learns the same, and therefore we can't teach everybody the same way. So we just want to make sure that you understand a resident and the student's learning style. A few residency programs, and if you read in the literature, talk about knowledge-based tests. I don't think we do that here, but I know of other programs that do, as well as skills assessments. I think the most important thing to discuss, if there is too much, but it has to be discussed, are the goals of the learning experience for both the resident and the student learner. That is going to really set everything off on the right foot. The next thing we have to do is make sure that we maintain our professionalism. It can't be said enough, but they witness our interactions. So we have to model as preceptors the proper interactions with the team and other colleagues, including our interactions with the resident. I think that another thing that we can do in modeling is provide tips on interacting with the team and provide when we're providing a recommendation. I like to tell my residents and give my residents or learners suggestions on working with challenging providers, just because I think that they can witness that, but I also, it can feel deflating to a learner when when a challenging provider just is someone that they have to work with just because that's who's on their team. But if you can give them suggestions and tips on how to approach that, that can be really helpful. And of course, maintaining professionalism is prioritizing safe patient care and safety before everything else. And obviously we want to hold our students to the same professional standards and our learners to the same professional standards that we hold. Communication is key. We want to make sure we communicate with the students who the team of preceptors are and make the introductions and provide the students with the preceptor schedule. We on our rotation and most of the rotations we make like an Excel calendar and then we load it into Teams for everybody to see. I think ICU also does something similar where all the documents are shared document in a particular folder. I think that the most important thing is if you can find a central place and communicate clearly that this is where the learner is to find everything, or tell them we communicate via Volt, or we can communicate via the phone, or we communicate via email. It's establishing that is really important for the learner. And then make sure that you're constantly helping to set up the appropriate time for feedback. And that includes the early feedback. You can incorporate feedback Fridays. Of course, the scheduled midpoint and a final evaluation. I think one thing that we like to do sometimes on our rotations for oncology is we like to, when we transition from one resident to another rotation, we like to transition between the preceptors just to say, this is what they're doing well. This is probably what the resident does this too, but I think that preceptor to preceptor can help with the communication in the resident and the learner's learning. And then it's important to communicate about the particulars of a student's progress for continuity's sake, or the learner's progress, just so that there are areas that the future preceptor knows to help them work on. So I can't emphasize enough in communication, providing regular feedback, whether that's in person or via Zoom or through some meeting, is incredibly important. And that's going to really help their learning and hopefully their performance. So feedback should be regular and often. I've talked about feedback Fridays. I think we all know kind of that sandwich method that you can use, especially for the learners who may struggle a little bit more. But I think the more important thing is that feedback needs to be consistent. If the resident is giving feedback to the learner that is inconsistent or doesn't agree with the primary preceptor, that's going to give a lot of confusion to the learner. They're not going to know what area they should be focusing on. And I think it would be good to have a provider and the learner, the pharmacy preceptor and the learner provide the opportunity for independent objective feedback. So I think most of us, what we do is we'll let the resident have the feedback with the learner, and then we'll check in with the resident for the feedback. I like to discuss with my resident if I see that same, if I see that same, if I agree with that feedback and if that's something that I'm assessing as well. And if we don't agree on that, then we have a discussion of our own. But I think the important thing is that it needs to be a continued process of evaluation and communication. And so just going, I think this is just like a nice diagram to show that you'll have supervision and roles and that, and you'll also have the learner progress and assessment and consistency and expectations, but all that feeds back into the communication between everybody. So in summary, the number of learners is increasing with the expansion of the schools and residency programs. But what we've seen is that the layered learning practice model is a really nice model that provides a strong structure for co-precepting. The primary preceptor, however, has to invest the time to plan ahead. You have to make sure that you set clear expectations of both the resident and the learner. Ensure that there's a strategy for communication. Do it regularly and do it often. You want to have a consistent approach for supporting the learners. And then you want to involve each participant in the care of the patient as much as possible. I would, and that is a delicate balance, but if the resident feels invested in the care of the patient and the team, if the learner feels invested in the care of the patient and the team, then everybody feels like that they are, that they have an active role. So if you can just put into the Zoom, just your answer, but all the following are useful strategies for co-precepting, except A, discussing responsibilities and roles at the beginning of the rotation, feedback every week, providing feedback at transition of rotations, communicate clearly the expectations, following the learner on social media. Yeah, great. I don't know if everybody else does this, but I make it a habit not to follow any of our residents on social media until after they're completed the program. We can talk about this another time, but I just do that because I don't want them to feel like they're being scrutinized or that they have to be like, I mean, they should conduct themselves in a proper way, but I just think that it helps set that boundary that's appropriate for being a preceptor. But that's just, hopefully many of us are maintaining that professionalism. And then this last question actually is, what are the benefits of the layered learning practice model? Increase patient satisfaction, increase provider satisfaction, reduce drug costs, expanded clinical services, or E, all of the above? And yes, we've had several studies to show that all of the above can occur with the layered learning model. So if you all want to unmute yourselves, I actually have a few scenarios here that I would love to discuss. Some of them have actually happened and some of them are more posed in what I read in some of the literature, but I would love if we could kind of have more of a discussion about this with the time that we have left. So the first scenario is you are a pharmacy preceptor for the infectious disease service, and have oriented with your PGY1 resident a plan for your student learner, including calendar and delegation of responsibilities. On the day that you and the PGY1 resident orient the student, she makes a comment about not enjoying hospital rotations because she already has a job to work at a pharmaceutical industry. I'm just curious. I mean, I'm just curious what everybody's approach would be on who would want to take the lead in discussing with the student. Do you not want to discuss with the student? How would you guys like to best approach this situation together? Okay. I'm going to tell you guys, this is actually something that happened to me on a rotation when I was a resident.
This is Kathy. I'll take an initial stab. I would maybe try to incorporate their interest in their future career path with the current experience that they're having. That if they're working for a pharmaceutical company, these are the patients that they potentially could be treating. Just sort of try to leverage the common interests. And then maybe if they're still sort of disingenuous about it, maybe take a different approach. But I would try that first, maybe just relate to how it can tie into what their interests are.
Okay, I like that. I was the resident at the time, and my primary preceptor, you know, he'd been teaching for 20 years. And so when we had that discussion, because it actually was, it didn't just start on the orientation, but it was apparent through the first several days of the rotation. And he said, why don't you as the resident take the lead? You are closer to her in learning. And so she may relate to you more. And then also, then he would come in and say, I've read so many of these studies. You're going to have to learn about study design. You're going to have to learn about outcomes. You're going to have to learn about all of these things that are important. So we kind of delegated, responsibility of who would approach the student in which way. But I think the only reason why I brought this up was, when would the pharmacy preceptor want to take the lead on it versus when the resident would? And I think in some situations, it's possible for the resident learner to, if they feel comfortable to do that, as many times they're also right out of school, like similar to the student, versus having been in practice for quite some time.
I agree. I would have the resident give it a first pass and maybe ask the resident what their strategies are, because they might have something that's more relatable since they're closer in time in terms of like schooling and experience.
I mean, I thought that was a really good approach that we had. Not everybody is going to take that same approach. But it was interesting, co-precepting. The next scenario that you're going to be co-precepting, let's say you're the clinical pharmacist and primary preceptor on medicine. You notice that your student is not making recommendations to the team despite having discussed them ahead of time with the PGY1 resident on service. They seem to be quiet and standing away from the team most of the time. Who and what is the best approach for discussing with the student? I'm going to preface this with, I think many of us would know what we would do if there was no learner, no resident in the middle, but I'd still love for us to talk about it. Have you guys ever had a resident who was just so shy and didn't want to talk to their team? Oops. Well, I will say the approach again would be, one is I would continue as the resident or as the preceptor and have the resident, both of us, model our interactions with the team. Maybe have the resident sit down with the learner and discuss like maybe some of their challenges. They may be more willing to open up to like the resident. And then I think the important thing is, if we have goals, what are the steps we can take to help them become more incorporated into the team. Alrighty. I just have a few more minutes, but this next one for the co-precepting was that your student makes a recommendation to renally adjust a medication that the pharmacy preceptor and the PGY1 resident have agreed would be appropriate for a patient. The student approaches the medical intern with the recommendation, including providing primary literature. The intern indicates they do not agree and does not want to change the dose. How do you guys handle the situation as the preceptor? Are you going to have the student try again? Are you going to have them approach the attending physician? Would you like the resident to help facilitate the interaction? Would you as the preceptor discuss it with the intern yourself? Does anybody have any thoughts about this? Well, I have come across this scenario many, many times in assessing the learner, because they did make a recommendation, I would have the resident work with the learner to approach the intern again. And what's happened is I've had that intern tell the resident no yet again, and then I had to step in myself and then tell the attending that this is what we need to do. But I think, again, it's in this piece, facilitating the autonomy and independence is really going to be a good co-precepting tool to use so that you can enhance the learner's experience. And so I was just going to leave, I mean, we only have like a minute left, but I was going to leave an open forum for anybody who wanted to share any of their own pearls about co-precepting that wasn't already discussed, that may not have been in the published literature. if anybody wanted to share anything with the time that we have left. Have you guys encountered any unusual scenarios?
Hey Laura, this is Tram.
Hi. Hi, Tram.
Hi. I really loved everything that you shared. I think the one of the big pearls, I mean, just listening from what you had presented, just about co-precepting is, just being on the same page as learners, like they're having to manage different types of preceptors too and their expectations. And so, also like as when you're co-precepting, just being on the same team and kind of that handoff, I think you touched upon that. So that way, the students don't feel like they're dealing with different, like they're on the same rotation, but it's not so different that they are thinking that they're having to, search for like how to best, navigate the rotation.
Okay, yeah, I would agree. I think that like being on the same page is probably the most important thing that you can do for everybody to be on the same page. If there's only one thing that we take away from today, it would be that is that to be on the same page as your learner and as the resident. I'd agree with that too. Thanks for sharing.
I was just going to share that I think in general, I've only gotten positive feedback when we have layered learning. The students often feel like they have sort of an intermediate preceptor and then an immediate preceptor, and the residents generally have a really positive experience sort of helping to guide the student learners. And
that's good to hear.
Yeah.
We trialed a PGY2, PGY1 student and then pharmacists complex. That seemed like a really complex layer. And I don't think we had the same outcome. And maybe what that was too many. But I'm glad that.
Yeah, we don't get to do it too often where we have the ability for the students and the residents to interact, but we've had like some projects like med pass observations and things like that, and we've gotten really positive feedback. And like just going back to my own experience as a student, even though it was more than a decade ago, like I still remember being on like an oncology rotation and interacting with the PGY2 onc resident at that time, and it was like a mutually positive kind of experience, and just sort of allows an extra resource, I think, for the student to be able to ask questions too, because sometimes it can be like some of the stuff you shared in the slides, scheduling or things like that might make it challenging to have as much face time with the pharmacist preceptor. So, yeah.
Right. Well, I thank you guys for sharing, and I had a really great time discussing this with you. I just think reading about this more and then putting it into practice is always very useful, just being more aware of it. So I just want to thank you guys for your time, and I'll stop share. Thank you guys.
Thank you so much, Laura, for your presentation. How wonderful to hear about all of the things that you guys are doing and how we can emulate them. I am going to give everyone just a little bit of break before we start the next session with Dr. Tram. So it's 6:03 now. I'm going to plan to resume at 6:10 if that sounds good for everyone. So I'll pause the recording now. We'll meet back at 6:10.
So much, everyone, for joining. I know, like Dexter had said, this has been a very long day for you, I'm sure. So hopefully I'll try to end this on a fun note, and that you had an opportunity to complete the emotional intelligence tests. We'll go over that during the presentation and kind of make sense a little bit with that. So with that, what I really hope to achieve in this presentation is really try to, have you as you're discovering your emotional intelligence and where your strengths and maybe areas that you can improve, how to really ultimately help you to become a more successful preceptor. So these are the objectives for this presentation. I'll briefly go over the framework of emotional intelligence. There's different kinds, but the one that I'll be referring to is by Goleman. I'll also go over and discuss how EI can be integrated into pharmacy education and training. And then what I hope to achieve is that we do a lot more interactive in the session too. So feel free to share and talk about your appraisals and strategies. And then lastly, I'll be presenting some precepting scenarios so that we can apply emotional intelligence in those different scenarios. So what is EI? It's the capacity to recognize our own feelings as well as those of others, motivating ourselves and managing emotions effectively in ourselves as well as with others. And really, emotional intelligence, as you can see in this tree, it really is such an important foundation for critical skills. As you can see in the tree, empathy, being able to have more empathy, how to deal with stress, tolerate that, anger management. And with that, there's accountability, flexibility. So much of what we deal with in everyday life within ourselves and with others, we really have to use emotional intelligence. And I kind of briefly said this earlier, in that the framework I'm going to be mostly referring to is by Goleman. There are many, but the reason why I use Goleman is because it's actually one that's probably the easiest, I think, to follow and remember. And it's based on 4 domains: self-awareness, self-management, social awareness, and relationship management. So in the next coming slides, I'll go into depth a little bit more within each of these domains. So in my opinion, the cornerstone of EI is self-awareness. So when one is self-aware, you'll have you'll be able to recognize your own emotions and their effects. So as an example, if you get yelled at by your boss for an error that you are not responsible for, that makes you extremely angry and probably want to yell back. But recognizing that your anger could damage the integrity of the relationship with your boss, you would then decide to take a breath and maybe think about what you want to say and how you want to say before responding to your boss. Another part of self-awareness is the accuracy of doing that self-assessment. So knowing your own strengths and limits. Another example would be, when you are really good when it comes to time management, for example. You are really on top of staying organized. However, you are not really great at thinking outside the box when you're required to maybe develop a new program. So knowing that, you always want to pair yourself with someone else who is great out of the box thinker. Another aspect is self-confidence, and I think this is pretty evident in just the words itself, is that having that strong sense of self-worth and capabilities. So the second major domain is self-management. And with this domain, there are 6 characteristics that are important in demonstrating self-management competency. Emotional self-control is where you keep these disruptive emotions and impulses in check. So going back to my previous example where you are yelled at by your boss, because you have that self-awareness, it enables you to keep your anger at bay, and as a result, help you to exercise that emotional self-control. Transparency is maintaining integrity and acting congruently with one's values. So again, going back to that boss example, while you didn't yell back, you also want to still be as honest as possible with your boss, to at least let them know that, how you feel. I know it can be kind of difficult sometimes to do that, but that's where that transparency. So kind of still staying true to yourself to let them know, where it affected you, but then also conveying your thoughts in a calm and respectful manner, and really using those I statements. And the remaining 4 characteristics, adaptability, achievement, initiative, and optimism, are all important qualities that are indicative of successful individuals who, as they are flexible, because they can easily adapt to change, they're always striving to achieve excellence in everything they do, they see opportunities and go for it, and are resilient. They are persistent in pursuing their goals despite obstacles and setbacks. Social awareness is the third domain in the EI framework by Goleman, and it focuses on empathy, organizational awareness, and service orientation. And Goleman calls this domain the quote unquote fundamental people skills. So to be socially aware, it's important to have empathy, sensing others' feelings, perspectives, and really taking an active interest in their concerns. An example of this is when, say, you have a friend who you're working with on a project, and appears to be annoyed or bothered whenever you ask if they've completed their part of the project yet. And so upon talking with your friend, you learn that they have been caring for their sick father, and having gained that insight and understanding the emotional exhaustion and physical exhaustion that they've been enduring, you suggest to them that, maybe divide up that work with you and maybe other team members, so that they can, refocus on caring for their father. Social awareness also means that one needs to have organizational awareness, which is the ability to read like the group's emotional currents and power relationships. And service orientation, which is the ability to recognize and anticipate other individuals' needs. So imagine that you've been informed, as all hospitals are impacted by this, is, SB 1254. So now there's a departmental priority that this needs to be implemented. So in anticipation of this, you assess how learners can help provide some support in a meaningful way as part of their learning experience on rotation. So hopefully it becomes more of a win-win situation, as you know that you'll have to be doing this as part of your work in some capacity, but then try to really leverage others who are working with you so that they gain some of that experience. And again, try to marry that and make it as meaningful as possible as part of what you already have structured in that learning experience. The last domain of the EI framework is relationship management. And this domain is sometimes really the hardest area, I think, to work on. Many of the characteristics found in this domain are descriptors of what really makes a good leader when working with others. So really knowing how to develop others so they can be the best version of themselves and improve their abilities, to inspire and guide others and be that catalytic change. So someone who excels in relationship management is also able to be persuasive and influence others. They manage conflicts well by negotiating and resolving disagreements. They're also very collaborative and they model behavior of a great team player. Teamwork and collaboration is when working with others towards shared goals. So creating that group synergy and pursuing collective goals. A good example of this is someone who's demonstrating strong relationship where, say, you have pharmacy leadership whose goals is to really increase pharmacist visibility in patient care areas by, say, increasing patient education. Leadership has identified pharmacists who support this initiative and engage them to serve as champions for the project. The champions work with their colleagues to develop a plan that would help the department to achieve their ultimate goal. They design the workflows and metrics to determine the pilot success. And based on those favorable results that were obtained, the rest of the staff were happy to support house-wide implementation. So now I'd like to kind of segue a little bit in how EI can be applied in pharmacy education and training. Well, I think you're probably really familiar in that it's pretty well recognized that emotional intelligence has been well publicized and utilized in the corporate world. And as the field of pharmacy practice continuously evolves, there's been increasing interest in developing emotional intelligence for pharmacy trainees to help set them up for professional success. And in this figure here, the boxes that are colored in green, dark green, is really where EI could be applied in the pharmacy curricula. And as you can see there, it's pretty much in a lot of different areas and facets within the curricula. So really having strong emotional intelligence will help to ensure positive educational and professional outcomes for learners. The development of EI has also gained interest within pharmacy postgraduate training, and the higher EI will help postgraduates achieve goals and objectives outlined within the PGY1 as well as PGY2 competency areas. And what I've kind of listed here, at least in the PGY1 residency competency areas, are areas and domains in which really where EI could be most applied in. So based on what's been observed and studied, emotional intelligence has been associated with job satisfaction and commitment, interpersonal and communication skills, personal management, including stress management, adaptability, and leadership potential. And so with that, what I'd like to do now is really go and do a deeper dive in talking about the EI appraisals and your EI appraisals. So what does your EI look like? So if you recall, again, the EI framework, at least the one I'm referring to by Goldman, is made up of 4 major domains: self-awareness, self-management, social awareness, and relationship management. The top 2 on the slide are more about you individually. It's really how you use EI in situations that are more about you privately. And combined together, they make up your personal competence. The bottom two skills are more about your interactions with others, more about how you are when working with others, and combined together, they make up your social competence. So let's try to make more sense of the scores. If you score in the 90 to 100 range, it overall means that it indicates a noteworthy strength for you. If you score in the 80 to 89, it's above average, but there's still room to improve. Consider how you may want to polish your skills. If you score between 70 and 79, you're aware of your behaviors, but some EI behaviors are holding you back. If it's 60 to 69, sometimes you demonstrate EI behaviors, but not usually. And maybe in some cases, you may let people down. Skills may not always come naturally, or you don't make use of it, therefore need to practice more. And if you score 59 or below, the skill is either a problem for you, or you don't value it, or you didn't realize it was important. The one thing I really like about emotional intelligence is that it's not a stagnant score, and it's something that you can develop and build over time and improve on. And so really with more practice, it does improve and it does get better. The other thing I want to make a note of is that when you're in the mind, depending on where your mind is when you're taking that test, I also personally think that it can impact the score as well. Because depending on if you are thinking more of what's happening in your life, personal life versus your work, your application emotional intelligence may shift a little bit. So I think that's really important to take into context when you're trying to make sense of your scores. So in the next several slides are some suggested strategies that I hope will help you as ways to improve emotional intelligence in each of the domains. So if you score lower in the self-awareness domain, here are some suggestions. First, know who and what pushes your buttons. So what are the triggers? Maybe keep a journal about your emotions and write them down. And I think one thing that we really try to do with our students is help them to reflect. It's not just looking back on what happened, but really critically look at who are the players, what are the contributing factors that led to that, and really moving forward, how can that be prevented in the future? And then really to understand your strengths and weaknesses. So if you are familiar with the SWOT analysis, the strengths, weaknesses, opportunities, and threats. So really do a personal SWOT analysis so that you have a better understanding of your strengths and weaknesses. And then, of course, seek feedback, because usually through feedback, it helps us to do, a whole 360 on evaluating ourselves. So if you scored lower in the self-management domain, here are some suggestions. Again, know what triggers your feelings, anxiety, and stress. And maybe if you don't already practice mindfulness, that's very helpful as part of that, helping to, that self-control. Learn to pause before responding, perhaps practice, sleeping on it, or count to 10 before responding. One thing that I personally like to do, I like to use the acronym THINK. So, T stands for, is it thoughtful? H for honest. Is it intelligent? Is it necessary? And is it kind? And if it doesn't meet any of those, then I tell myself probably I shouldn't respond. And then another thing is to really try to take responsibility for your actions and behavior. So hopefully through that self-assessment, think how you want to, respond and take actions for those behaviors, and ensure that those align with your core values. Another important aspect of self-management is taking control of your self-talk. So maybe something that didn't work out so well, you don't need to punish yourself as much. And I think we are all our own critical, very critical of our own selves. And so part of that self-management is to not do more negative self-talk than you need to.
I thought this one was really interesting, Tram. Sorry to interrupt. But hearing like the strategies was I scored relatively low on this one compared to all the others in the 70s, which I thought was kind of interesting, because I thought that I was a relatively self-aware person. But then when I looked at the strategies, like I do respond to things very quickly. And sometimes I don't take the time to like decompress a little bit about it before I respond to stuff. So I just thought it was fascinating how you can think that you're self-aware and think that you're on top of those things, but really the value of understanding your limits and everything is a little bit different than your perception.
Yeah. And honestly, like just because you're not as high in some areas, I feel like it fits to maybe even the practice area. So you're a critical care pharmacist, right? Like you need to act fast. And so I feel like there's some added value. I think it's when then hopefully, you redirect appropriately. Thanks for sharing, Dexter.
Yeah, sorry to interrupt.
So social awareness. So here are some suggestions. I think, like I said, this is the people skills, right? So being aware of others, really do practice that active listening, watch and listen, seek the whole picture before responding, understand from their perspective, don't interrupt, and really try to make time if possible. So that way, again, it helps you to kind of put things into perspective before, reacting or responding. And lastly is that relationship management. So be open and curious. I think the key thing with relationship management is, ask yourself, where do I want to go with this relationship? And a lot of the time, it's really preserving that relationship. Or maybe even if it's a new relationship, how do I develop that trust and rapport so that we can have a better working relationship? In terms of enhancing your communication style, really try to figure out, like in this relationship, do I need to be more direct with you, or is indirect, like, do you get it? Are you the kind of person where I have to be more serious or maybe entertaining? So just really understanding like what kind of individual that you're interacting with, and how they perceive things, and adjust that way. Again, ultimately, it's all thinking of with the mindset that, we're trying to preserve that relationship or build on and make it better. And I think relationship management goes down to really have that conflict management piece, how to deal with others, as well as in difficult situations. So since we don't have as many people, I was going to do originally breakout sessions, but I think we can just talk about it here. So what I'd like to do, and as comfortable as you feel, I'd love to hear, and thank you, Dexter, actually, for starting us off and sharing, your where your strengths are, your highest EQ skill score. And you don't have to say your exact score, but maybe like where your lowest are. And I guess, what do you think are some strategies you can practice on to improve the skill? And what will make practicing those skills challenging for you? So I think before that, I'm more than happy to kind of share like where my EQ appraisal was, in that my highest is self-awareness. But my lowest, and that comes as a surprise to me too. So you're not the only one surprised, Dexter, by yours. I thought I was pretty good in controlling myself. But I think honestly, when I was taking the test, a lot of this too, I was, thinking about how I am as a mom, maybe at home. And so I am a little bit different at home versus like in the workplace. And so my threshold, I have to say, at work is a lot higher than at home, perhaps because I'm very tired at the end of the day and I don't have as high of a threshold. So like when things bother me, I let it kind of loose at home. But then that's where I need to learn, how to that self-control. So rather than responding right away, I try to sleep on it, or I write it down, or I practice a lot more breathing techniques. So those are kind of the things that I've tried to do. And I think it's really helped me a lot. And I definitely use that THINK acronym. So at this point, I guess I'd love to hear if anyone would feel comfortable sharing.
Hey, Tram, it's Laura.
Hi.
I feel like you spoke to me, especially about the low EQ skill score. We actually took these when we were back at Mount Zion at the Cancer Center, so several years ago. But I think mine is still true because my kids were really young, and self-management was the hardest for me and the lowest. And seriously, you're just speaking to me. I bet you, yeah. I felt like in the way that you explained it, it made sense. It makes sense why you have like no outlet. You're like everything's at work, and when you're at home, you have no outlet. I don't, but yeah, you're literally like speaking to my soul right now.
Thanks, Laura. Yeah, so I think that's why it's not necessarily work related. I think it's where your mind is for sure when you're taking the test too. Maybe there is a tendency there too, but yeah. Anyone else like to share? Thanks, Laura.
Sorry, Tram, I would totally share, but I didn't actually take the test. That's why I have nothing to share. Apologies.
Yeah, no worries.
Netta, I still have a book for you if you'd like to come grab one next time you're on campus.
I would definitely hit you up on that. I'm super interested. Yes.
I'll leave one in Mandy's office with your name on it.
Oh, perfect. Thank you.
Of course. Tram, I was the exact opposite of you. So my highest score was self-management and my lowest score was self-awareness, which is interesting when I think about it, because, maybe I manage myself and handle myself in those situations without sort of knowing that I'm doing it, or maybe there's some situations that I could manage a little bit better and improve from both of those standpoints. I will definitely use the THINK acronym. I think that that's really good and a nice way to organize my thoughts. I think my self-management probably comes a lot, as you were alluding to, in the self-awareness of like critical care, emergency medicine, of like dealing with really tough situations and really like emotionally scarring situations at times, and just having that experience is really helpful to like manage your own feelings, or how you deal with situations, or how you approach those difficult conversations with either providers or family members when the time comes.
Yeah. I do also, like, even me personally, I sometimes have a lot of, I put that empathy is like so strong that I think it's becomes debilitating, at least for me. I think that's where the self-management comes in, because I just feel so much. And then I just like it's bottled up in a very unhealthy way. So thanks. All right. So I think that's enough. If no one else wants to share, we'll move on.
I
So, oh, yeah, go ahead.
Comment. Yeah, sorry. I also didn't have a chance to do the assessment yet. But I was just going to share, like, I feel like similar, like you said, which one is your highest and which one is your lowest, but it still doesn't mean like one is like a weakness. It's just you gravitate more towards one realm than another, sort of like with the strengths finders. It's like, here's where you excel, and then here's where you can try to focus on improving if you have room to grow, kind of a thing.
Yeah.
On the one of the slides, I think it was one of the, I can't remember which slide it was. I don't remember if it was it was this one. No, go back.
This one?
No,
This
the one before that you were just on. Yeah, the try not to talk about your own feelings during conversations. I feel like sometimes people, myself included, might use that as a strategy to like relate to someone, but then also it takes the spotlight off of what they're doing. So you have to walk that line carefully. And I would agree that it's probably best to err on the side of following bullet 3 versus trying to relate too much that you then detract from whoever is doing the talking.
Absolutely. Yeah, I find that you hit it right there on the head there. Definitely. Okay, so I think in this next part, I'd like to go through some precepting scenarios, and really I'd like to get your take, how you would respond, and how you would manage a situation, and then kind of tying it back to these domains, how these those actions are tied back to those specific domains. So in this first one, you're meeting with your student on their first APPE acute care rotation. It's a hectic day. It's your first day back from a long vacation. You need to rush off to a meeting. You quickly review the rotation schedule, reading materials, schedule topic discussions, and project and presentation assignments with your student. Your student looks lost and overwhelmed. You can tell that the student has several questions, but you're already running late for your meeting. So what should you do next? How should you respond?
Maybe letting your student know that you're aware that you just dumped a whole lot of information on them, but you're more than willing to set some time aside when your schedule frees up a bit to kind of go over things in more detail and answer any questions that they might have.
Great. Yes.
I agree. I feel like when I have these situations, I'll say something similar of like, this is a lot of information. Why don't you take a time to digest it while I'm in this next meeting? And then maybe afterwards we can spend a couple minutes answering any questions that you have. That way it's a cue to them that you're going to circle back with them, and you know that it's a lot, but you also know that they're overwhelmed by the information that you just shared.
Yeah, definitely.
The top box.
Agree with everybody.
Yeah.
Dedicated
So-
time to talk to them later.
Mhm. Great. So yeah, I think you all that would be very similar approach that I would take too. So I think the first and foremost is to, that have that self-awareness that, you're in a rush and that you have dumped a lot of information to them, and that's caused some feelings of, maybe overwhelm feelings for the student. And then also with that, you recognize that this is the students also, it's their first APPE rotation, and, who knows, they don't know what to expect, a lot of unknown for them. And so really taking that moment, at least before you rush off, to let the students know that you'll set aside time later, maybe in the day or once things slow down, to answer questions. And I really like what you said too, Dexter, is that, take this time to try to digest the things that I've already covered. And then if you have any questions too, we can talk about it later when we meet again. So really, I think this is important to kind of like set that tone, because this is reality, right? It's always crazy and hectic, but it's their first interaction and impression of you and just the workplace and learning environment. So establishing a relationship where the student knows that even though you're busy, you do want to create a good learning environment for them so that they're clear in understanding, what to expect in the rotation and of them while on rotation with you. So great, thank you. So yes, I would say in this scenario, all 4 domains is being utilized. Okay, so in this next scenario, you during a midpoint with your student, you provide some constructive feedback on better time management and better patient workup. You have provided this feedback along the way during the rotation. The student then says to you, they're surprised to hear this as they have never received this type of feedback before. How many of you have ever had that response? Kathy, I see. Oh gosh, yeah, right. So, how would you respond?
I tend to ask, well, what feedback have you received? Like, what feedback has been given to you in the past, and what have you heard? Because I think for us in the ICU group, we often have different ways of delivering the feedback, and sometimes that message isn't perceived by the learner. And so if they've been on other rotations where other preceptors have given this feedback, they may not have realized they were being given the feedback, and helping tie those connections can help them in the future for like really understanding and cluing in on what the preceptor is trying to tell them to improve.
Yeah. So this other piece to this though, Dexter, is that in this rotation, you've already identified that with the student too.
Oh, you personally have provided the feedback.
Yes.
Oh.
And that for some reason, they are still surprised to hear this.
I misread that. Apologies.
Yeah. It's okay. No worries. Does that change things a little?
Yeah. I think, we document everything in the residency program. So it's sort of helpful from that standpoint where I can look back and say like, hey, we've talked about this before. Here's where we talked about it. But outside of the residency program, I think it might be helpful to just revisit like, hey, remember the conversation that we had 2 weeks ago where this is what we talked about? Like, what did you take from that conversation, or what did you learn, or this was the goal that we set out?
Yeah.
What's going on?
Yeah. Sounds good.
I would probably evaluate how the feedback was given the first time and recognize that whatever that delivery method wasn't effective in the way that I had thought or hoped or planned. So if it was just verbal at that time, this time I might do verbal and written feedback and maybe discuss like an improvement plan, like, okay, in order to improve your timeliness or your time management, let's try these strategies A, B, and C. Like at the end of the day or at the end of the week, you can provide an update on X, Y, and Z or something like that. Like I would maybe not think that they're lying or arrogant or whatever, but just maybe reassess that communication wasn't as successful as intended the first go around.
Yeah. Does anyone else have anything to add?
I think that acknowledging their feeling that so that they rather than saying, oh really, you've never heard this before, okay, versus acknowledging that perhaps they've never perceived it before is to validate their like them, the learner. But I also agree with Kathy. Anytime someone gets feedback, you need a plan to improve that, to work with them, whether they perceive it or not. Just developing something so that they can meet goals or of their rotation or something like that is very, very useful. And I would agree with doing that to help them along.
Yeah, I think all of you brought up some really important points there. And I think the key thing here, and I'm being sly a little bit here in that, actually, let me go back here. So you provided some constructive feedback on better time management. So the word, and this is a real situation in that, I think we think we often give we give feedback, but to the students or the receiver or the resident, they may not clue into that that's feedback unless you kind of have to be very black and white and go, let me give you some feedback. And the reason why I know this is because I sometimes hear from students like, they didn't say this, but then to the, the preceptor, when I've talked to them, they say, no, I've told them they need to do X, Y, Z. But it's sometimes like in passing. So the student may not put things, all together. So what does better mean? I think Kathy, you kind of, clarified that a little bit better in that, it's how. So, if you don't give them specific ways and how to improve, they may not really realize that. So I think the other aspect is, and Laura, you mentioned this too, is that that acknowledgement. I think that's important as much as maybe the learner may be off in like, well, I don't understand why you're surprised because I've been giving it to you all along the way. But there could be a miscommunication where, again, having that self-awareness, like, could it be me where I was not clear enough in how I communicated? So while you may be frustrated to hear this from the student because you've said that to them and shared with them, maybe just in time feedback, really try to reassess how you communicated to that learner. Of course, remain calm and control your emotions, but again, apply that, active listening skills to hear the student out why they may not have caught on. And then really, again, reiterate, like, this is what I've said. And I really like your approach, Kathy, is, having it written. Sometimes it's just trying to figure out different avenues so that way it's clear moving forward. So yeah, so that's all I have to say. Does anyone else want to add anything? Okay. So yeah, with this one, again, it really touches upon all 4 domains in which you have to kind of take into consideration in handling the situation. So the last scenario that I have is more related to conflict resolution. During the second week of rotation, you have to modify, I'm sorry, I keep using students, it doesn't matter, learner, but you have to modify the learner's schedule a bit to integrate some TOC activities during their learning experience. This change will help to meet new departmental priorities and provide the students an invaluable learning experience. When you break the news, the students remain silent and appear upset. What should you do and how should you respond? I feel like in some ways it's probably happened at one point or another, right? When you're kind of given a directive, like, we need to do this. It's another thing that we need to deal with.
I've had to make a student course on a project, like their research project, or not a student, a resident, but I just let them express how they're feeling first, and then say, they're completely valid in feeling how they feel, because you recognize that you set up specific expectations, and having to change course can be very difficult for a learner. So that would be the first thing, is just to kind of just let them allow themselves to feel that way and express it to their preceptor.
Yeah. So really having that social awareness, like where their perspective is coming from.
Yeah. And then once they've had that chance, I would say, okay, well, we all have to meet this goal. Let them think about ways that they can meet this goal, and give them some say in it so that they feel like they have like a part in it rather than being voluntold. They can at least have some say in how they meet that.
Yeah. Kathy?
Sorry, I couldn't unmute for a sec. Yeah, I like everything that Laura said. I was gonna just maybe add, like, maybe explain to them the context or the background as to why, and also explain that it's unanticipated for you as well. Sometimes just knowing that they're like why it's a priority or why the change or sort of that thing. And then maybe asking an open-ended question of, well, you know, what questions do you have? Like, because if they're silent and appear upset, I don't necessarily want to like stoke the fire, but I want to be able to put them at ease or sort of find out what concerns they have to help sort of, I guess, just like improve the situation. But at the end of the day, it is what it is. We got to do it, right? So
Yeah. No, I think both of you have actually like would handle this situation perfectly. So I think the first and foremost step is to acknowledge the impact that this change will have on the students. And so I think, right, because it's a conflict. So in any conflict, it's just kind of like, I hear you, I see where you're coming from. And then of course, unfortunately, there's that but with that but is also providing that context, Kathy, that you mentioned too. You know, what the reasoning for the change. And almost, I think, you know, sharing a little bit of like, unfortunately, yeah, this is news to me too. I feel for you, and honestly, well, and really get them engaged in helping provide some input, right? I mean, they can't, it's not like they can say no, but at least like, how do you propose, and maybe like where we can have you do this so that it kind of ends up meeting the needs of for us, as well as maybe a learning experience for them. The other aspect to this is that almost reminding or letting them know that this is kind of honestly how workplace is sometimes, at least in healthcare, you know, really learning to adapt to new situations and trying to make the best of it. So perfect response. So in this case, really, I think that the two domains that are utilized is really social awareness and relationship management. So the key takeaways is, you know, hopefully you agree with me in that, you know, EI is really important as pharmacists, as well as actually preceptors, to become better preceptors and really in our working relationships with others. And that really, whenever you can, leverage those EI skills when interacting with your learners, so that you can hopefully ensure successful learning experiences for them. And again, like I said before, no matter where you measure in the EQ skill score over time, with practice, you can always work to improve it. So with that, actually don't have anything else that I wanted to cover, but unless, you know, you'd all like to share anything like precepting scenarios. I actually had so many more and I wasn't sure how long it was going to take. And Laura, actually some of your precepting scenarios I was going to include, where I did have a student who said they were only interested in industry. And it's almost like, why I'm interested in industry, I don't know why I have to be in this rotation. So it does require a little emotional intelligence to know how to best respond.
Do the residents get a talk like this?
They do, yes.
Okay.
That's good. I think it's helpful to keep in mind for the year. It's such a crazy rush year. I think keeping this in perspective is very helpful.
Yeah, they get it in the winter block. So right around the most stressful time of their year.
Oh, that's such good timing.
It's hard to figure out the timing for all these things. We do a lot of these emotional learning and self-awareness type of things throughout the year. And so we do Myers-Briggs. They just did it yesterday, or today, actually. Today's been such a long day. It feels like 2 days. And then Strengths Finder they'll do in the fall, and then the winter block emotional intelligence. And then they wite their own personal mission statement in the spring.
I forget when, but they made us do this test to like determine they made all of us at Mount Zion do it with like Helen and that group. I forget for what purpose, but when we were talking about it, I was like, this is a really good thing to revisit often, just because it makes you more aware, or just step back to think about kind of like your emotional intelligence. So I really like this, Tram. Thanks so much.
Yeah, no problem. I had fun putting this talk together. I think, I mean, this is one of the things that we talk to our students about too. Hopefully it helps them. But again, you have to practice. So,
Hey Tram, this is Lena.
Hey,
I just
Lena.
wanted to say, reading the book, I think this is the second time around that I had read it, but it feels really good to retouch on these topics. And I think one of the things that I really like about the book is it points out how EQ is like flexible and you can always improve in it, as opposed to IQ and personality, which is a little bit more fixed. And it's so empowering to hear that and remind yourself of that, because I'm higher in self-awareness, but a little bit lower in self-management. And to have a reminder that these are strategies to improve on. So you're not in this like, I'm a helpless person, I can't get better mindset, and to improve on that. It's a great reminder for work as well as personal life. So I really appreciated this talk.
Great. I'm glad. I almost feel like it'd be great to have just like all preceptors go through something like this, right? And I know it costs money. And actually, so this book, I know there's a cost to it, but there's actually like online EI tests too, and they're shorter. I think it's great to have that kind of conversation as preceptors, because then feel like we should probably have like a generational talk too, which I think we already did, right, Dexter? I feel like
Maybe. I can't remember at this time. Ask me on a better time of the day. Yeah, I would love to have like this type of discussion with a lot of our preceptors and this type of training with a lot of our preceptors. I think it's really fruitful to discuss these scenarios and sort of how we all would approach them. Because as you can already tell from the few people that are on this call, we all have very different sort of results from our EI tests. And I think that speaks to that. It speaks to the variety of preceptors that we have at UCSF and how we can better utilize those preceptors to overall improve our preceptorship across the board. And I think this is a really important component of it, because you can say things all day that are clinically relevant. You can give all the feedback you want, but if it's not being delivered in an intelligent way that the learner is receiving it and understanding it and able to do something about it, it doesn't matter.
yeah, I definitely completely agree. And I think that, in a fast-paced environment that we're in, where things are constantly changing, it's easy to forget like everything else that's happening around us. And this is my need and what I need to get done. And so I think this actually should even go all the way up to leadership, to tell you the truth.
I agree.
We just got them to do strengths finders. Maybe this will be the next year.
So thank you.
Well, thanks, Tram. Thanks, Laura, for giving these talks tonight. I know that many more people will definitely tune into the recorded versions. So rest assured, you will have a large audience on the recorded side of things. Speaking of, if anyone is listening to this recording and still wants a book, feel free to reach out to me. I have a couple copies that I'll keep one for you, but anybody else who would like to grab one, feel free to reach out and email me. I will send all of you a Qualtrics survey. It's looking like probably tomorrow on that, to evaluate for all of this and to claim your CE credit. You'll have 2 weeks to do it, so there's plenty of time. Thank you all for attending. Thank you again, Tram. Thank you, Laura, for presenting.
Thank you.
Thanks for running this.
Thank you, everyone.
Yes, good night, everyone.
Bye.
Bye.